Let's look at Chapter 16, Cardiovascular Emergencies. This is Part 1. Keep in mind that cardiovascular disease is the #1 killer of Americans since 1900, with it accounting for every 1 in 3 deaths. We can do a lot to help reduce the deaths associated with cardiovascular disease, both before the 911 call and the things that we do during the 911 call. We recognize the importance of ALS, and we encourage providers to become trained in that, and then we can also use the specialty centers, the cardiac emergency centers and cardiac care centers to help our patients. But until we can reach that point, we need to understand, recognize, and treat in a way that we can. So the heart's job is to pump the blood, and it moves the blood through the body, both to allow for oxygenation at the cellular level and to bring out the carbon dioxide. Remembering the heart is divided into the left and the right side and the upper and the lower chamber. This is a picture of the heart. If you're drawing a picture of the heart for you to study, then you can totally just draw 4 squares. You don't have to be an artist. And you can label the top ones the right and the left atrium, and you can label the bottom ones the right and the left ventricle. We also have valves within our heart and our cardiovascular system, and the veins as well. And the one-way valves ensure that the blood doesn't go backwards. We don't want the blood to go back from where it came. We need it to always be moving forward. Remember, the aorta is the body's main artery. It is what comes from the left ventricle, off of the left ventricle, and it is the first artery that transports the blood, all of the blood from the ventricle, into the rest of the body. So it is the largest artery. This shows you kind of that flow of oxygen into the heart, or oxygen of blood into the heart, where it is deoxygenated on the right side of the heart, and then it gets pushed out to the lungs for oxygenation, and then coming back into the lungs or into the heart with oxygenated blood and moving through the left atrium and the left ventricle, and then getting pumped out through the aorta to the rest of the body. You should have learned in your anatomy and physiology lecture that the heart has an electrical system controlling its heart, the contractions of the heart. It is a separate electrical system from anything else in the body because it needs to conduct the cardiac muscle in a specific way. That term, automaticity, is that electrical functionality of the heart. It relies on impulses from the SA node that goes from the top of the heart down. When the SA node fires at the top of the heart, it's going to contract your atrium. When no impulse is sent, the cells can create their own impulse, stimulating a contraction, but it's often not at the right level of strength. This is a diagram of the electrical conducting system in the heart. So you see that green dot is the SA node at the top of the heart, and it is going to contract and send that impulse, contracting the muscles, to the AV node. And the AV node kind of sits in between the atrium and the ventricle. And once the AV node fires, then you get that flow of electricity through the ventricles down into the Purkinje fibers, which allow for the ventricles to contract. And that is how we get that heart contraction from top to bottom. Why, when we place an AED, we put the pads where we do so that we can shock from top to bottom. The autonomic nervous system controls all involuntary activities. Remember, we don't think about it. It's an automatic process. The ANS has 2 parts, that fight or flight system, which is our sympathetic nervous system, so it's our reaction to sudden stimulus, and then the parasympathetic nervous system, which allows for various body functions to slow as the result of its function. So the heart muscle has to have oxygen, just like all the other muscles in the body. So while the heart is pumping oxygen to the rest of the body for functionality, it's also pumping oxygen to itself. When the heart needs more oxygen, We see the coronary arteries dilating, so getting bigger or widening, so that it can get a greater flow of blood and oxygen to the muscles. The stroke volume is the volume of blood ejected every time the left ventricle contracts. So a stroke volume is basically what you're getting out of the left ventricle, how much it can hold. The coronary arteries are those arteries that supply your heart with oxygen, the heart muscle. You have a right and a left coronary artery, and they branch immediately at the first part of the aorta. So basically, the minute oxygenated blood is coming out of the body, it is flowing to the heart. It is that important. So this picture just shows you the placement of the arteries, the coronary arteries throughout the heart and how they feed into the body. And again, you've got that right and left coronary artery, and they're going to break down into smaller branches to feed the heart. Where do we get our arteries and where are they supplying of blood, I should say? You can see these are the different arteries that we're familiar with. These are the larger parts. Remember, we go from the aorta to the arteries to the arterioles. So these are the large arteries, and this is normally where you're going to be feeling for a pulse. When you go to check your patient's pulse, these are oftentimes where you're going to be feeling. Now, we're not looking at the right and the left subclavian for a pulse. And you've got to consider where, the clavicle, the brachial artery, we know that's where we're checking infant pulses. Radius and ulna both have arteries. You have arteries that go through your right and your left iliac, which is in the hips. We know our femoral artery, we're fairly familiar with that. And then you've got anterior, so front and posterior, back, tibial and perineal. So those are going to be kind of at the knee and down a little further. From the arteries, we go into arterioles, and arterioles are smaller arteries. And then you get into the capillaries. And the capillaries is where you have that exchange of oxygen at the cellular level, and then the capillaries turn into the venules. Venules are the smallest branch of the vein, so you've got deoxygenated blood in there. The vena cava, so the venules feed up into the veins, and then the veins feed into the vena cava, which returns all of the deoxygenated blood right back into the body. And you've got both a superior and an inferior vena cava. The superior vena cava is what brings all of the deoxygenated blood from the top of the body, and the inferior from the lower. So the inferior is going to pull all of the deoxygenated blood from the abdomen, kidneys, and legs, and then the superior, your upper vena cava, is getting everything above that. We know if we have pipes, we've got to have something to flow through the pipes. So that's where we get our blood. Our blood has 4 components. The red blood cells carry oxygen and remove carbon dioxide when they function appropriately. The white blood cells are used to fight infection. Your platelets help a patient clot and form clots when there's a cut. And your plasma is that fluid that is moving those cells through the body. You should have learned during anatomy that the blood pressure is the force and the pressure at which the artery walls are under when the heart is contracting. So the systolic blood pressure measures the maximum pressure at contraction of the left ventricle. And the diastolic pressure, the bottom number, is the pressure when the left ventricle is at rest. Obviously, you don't want a patient, and you yourself don't want to have your artery walls under constant high pressure, because that's when you have significant damage occurring to your artery walls. We feel pulses at points where blood passes through the artery. Through an artery and normally over a bone. So when you are checking a pulse, you're normally doing so by pressing that artery against a bone or up against a bone to make it easier to feel. But each of those is the contraction of the left ventricle. So every time you count a pulse, it's the contraction of the left ventricle. When I tell you to check a peripheral pulse, or when your people in the field say, hey, check peripheral pulses, we're looking for pulses away from the central trunk of the body. So I'm looking for pulses in the wrist or down in the foot. And then central pulse, I'm probably looking carotid or femoral. This gives you an idea of where the different locations of the pulses are. You've got your carotid, which you shouldn't check both sides at the same time. We're not trying to choke our patient. The femoral artery, if you check a femoral pulse, you will not be in the bad area if you check it correctly. The brachial, which again is normally where we check our patient who is a pediatric, so less than 1 year. The radial, which is thumb side. Posterior tibial, it's going to be just behind the ankle bone. It's a little harder to find. If you do find it, I'd probably mark it. And then the dorsalis pedis, which is on top of the foot. Again, a little harder to find. If you happen to find it, I would mark it. Cardiac output is the amount of blood that is passing through the heart in a 1 minute cycle. So you know your stroke volume is when the left ventricle contracts, how much volume is in the left ventricle. Well, your cardiac output is going to be the full volume over the period of a minute. So when we find the stroke volume, which we don't in the field, if we were to find the stroke volume, all we do is multiply by the pulse. And that's going to give you the volume that passes through the heart over the period of 60 seconds. You know that perfusion is the constant flow of oxygenated blood to the tissues. And then we've reviewed the requirements for good perfusion. We've also reviewed for failure. So, when you don't have good perfusion, you're in shock. And if you treat, or if you fail to treat poor perfusion, you fail to treat shock in a timely manner, you will have patient death. And we're not trying to have patient death. So let's look at the causes, kind of how the chest pain and cardiovascular emergencies develop. And you have to start with the understanding that chest pain normally comes from ischemia, which is death of the cells, death of the tissue, as the result of decreased blood flow. So if you have a patient with who's had ischemic heart disease, then you are getting decreased blood flow to one or more portions of the heart. The bigger the decrease, the bigger area impacted, the greater the chest pain is going to be. And when the tissue doesn't get blood flow restored in a quick enough manner, the tissue will die. This shows you a picture of one of the causes of decreased blood flow, which is atherosclerosis. So atherosclerosis causes buildup of calcium and cholesterol on form of plaque inside the walls of the blood vessel. So it clings to the walls of the blood vessel, narrowing the passageway where the blood would normally run through. And when this happens, you end up with a significantly decreased blood flow and a higher pressure that it operates under. You can develop brittle plaque, so you end up with plaque that's going to block, that breaks off and becomes clots, which becomes an issue. When you've got a patient who has a big enough buildup of plaque and cholesterol and calcium on the walls of their vessels, you will get a full occlusion. So it will completely block the flow of blood in that artery. When the plaque breaks off, you end up with a thromboembolism. And a thromboembolism is a blood clot that moves and floats through the blood vessels. It may not stop as long as it is small enough to move through the different vessels. It won't cause a long-term issue. The problem will result when it gets lodged into an artery, especially if it is a major artery like your coronary arteries. So if a thromboembolism moves through the body and ends up in a coronary artery, but is too big to move through it safely, it will cause full occlusion, which when untreated will cause death. And that causes the acute myocardial infarction. So the sudden infarct or death of myocardium. a heart attack. So we've talked about it. Coronary artery disease is the leading cause of death in the United States. And we all have controllable factors that we can change, that we can impact, that we can adjust our lifestyle to try to limit how they impact us. On the screen are a list of a good number of them. So cigarette smoking, high blood pressure, high cholesterol, glucose levels too high, so diabetes, a lack of exercise, and obesity. Each of these is a factor that increases risk, and you can do things to change them. And there are a lot of things, though, that increase your risk that you have no control over. Being older, so you can't control getting older as much as we may try. A family history, coronary artery disease, atherosclerotic. So not only do you have plaque, but you're hardening of the arteries. Race, ethnicity, and just being a male. Being the male gender means you have an increased risk of coronary artery disease, of acute myocardial infarctions. We also recognize acute coronary syndrome. So it's kind of almost like COPD. It's kind of an umbrella phrase, which is caused by death of the heart tissues. Again, myocardium is the heart tissue, and ischemia means death. So, tissue death at the heart. And the two ones that we recognize are angina pectoris, chest pain, and acute myocardial infarctions, as we've talked about, heart attack. Angina pectoris, so angina or angina, is pain, and pectoris, the chest muscle. That's kind of the heart's way of kicking the patient and saying, hey, something's wrong here. So as the tissue begins to recognize that it has a decreased amount of oxygen, it will start causing pain. Normally it's a crushing or squeezing pain, often described during OPQRST as an elephant sitting on their chest, or as a band being wrapped, rubber band being tightened around their chest. It doesn't usually lead to death or permanent heart damage, because patients will often call 911 and get some sort of intervention, but it is a serious warning. You'll have patients who experience angina pectoris or angina pectoris every day, just in everyday activities. The problem we have is not the patients who recognize it and treat it, but those who kind of poo-poo it away as being something else. If you have a patient with unstable angina, there is often, there's no common denominator. It's not necessarily that you can recognize what's caused it or that it responds to treatment. So stable angina is chest pain that is responding to treatment that seems to be relieved by rest oxygen and nitroglycerin. Any patient who has chest pain should be under a high suspicion of becoming a heart attack patient. Heart attack pain, chest pain, is normally the signal that there is death occurring in the cells, in the heart muscle. And you have to remember that once cells are dead, much like a patient, once they're dead, they're dead. There's no coming back from dead. And you have about 30 minutes after blood flow is cut off, where you will start to see some of the heart tissue die. So not 30 minutes from when they call 911, but 30 minutes from the actual onset of chest pain. And our goal is to get them to that definitive care. And the goal for that is that they then get some thrombolytics, so what we call clot busters, or they get angioplasty, so they go in and they clear out the blockage to allow the blood flow to occur freely again with the heart. So your patient will present with a significant number of signs and symptoms, or they may present with none of them. That is the fun in EMS, is we're supposed to use more than just signs and symptoms. And, it's a big puzzle. But on your slide and on your screen, you will see the potential signs and symptoms that we expect to see in our patients experiencing chest pain, cardiac arrest. Well, not cardiac arrest, but cardiac emergency. When they call 911, many of these may be signs and symptoms that they report having. One of the things we're finding, though, is that these signs and symptoms depend on the patient. So women will have often what they call the silent heart attack because it doesn't show the way we're used to seeing it. It doesn't present with the signs and symptoms that we anticipate seeing. But some of them here to pay attention to is the chest pain or discomfort or pressure. It will often stay constant. So one of the ways that we talk about it, and it's not a diagnostic tool that has 100% accuracy, so keep that in mind. But one of the things that we ask our patient to do is, is it worse or better when you breathe in? Well, if it's chest muscle pain, so in the chest wall, not cardiac related, it would likely, or you anticipate that the patient would experience worse pain when they breathe in. If it's cardiac in nature, they will have pain that stays at a constant level, or should. We also see patients who have shortness of breath as a result of the pain, or we will see patients who talk about having pain not just in their chest, but in their arm and in their jaw as it radiates into those areas. Another good sign, death. So when your patient goes into cardiac arrest, it is probable and possible that it was caused as the result of a cardiac emergency. Understand that the pain associated with an acute myocardial infarction is different from angina pain. So angina or angina pain, again, it can be said either way, is normally shorter. So it occurs on exertion, it occurs for a shorter period of time. There is relief for a longer period of time when it is treated. When you have a patient who is having an acute myocardial infarction, it is not always going to be relieved when they take nitroglycerin. And the hope is that when they realize that the nitro isn't helping, so if they've had a history and they have nitro, the hope you have is that when they take the nitro and it doesn't help, that they realize that this is something more serious and call 911 or go to the hospital at that point. What are some of the physical findings that we have in our patients who are having a heart attack or significant cardiac compromise? Well, we're going to have fear, nausea, poor circulation. So they feel, because their heart rate is going to be different, whether it is racing or it's slowing down, there is that anxiety that comes with it. And here's what I love. What are some of the signs? You might have a faster or a slower pulse, or it might be regular, or it might be irregular. We don't have the guarantee that each patient is definitely going to feel or show the same signs and symptoms. We might have normal or rapid respirations because, again, when a patient has pain, it can cause increased respirations. We might have that patient, as I talked about, that has that impending sense of doom. But dear Lord, please don't ask that question. Do not ask, excuse me, but do you feel you're going to die? That's not a good vote of confidence for your patient. What are the serious consequences of the acute myocardial infarction? Well, probably your most serious is death. This being as the result of cardiac arrest, as the result of untreated cardiac compromise that then leads to heart death. Cardiogenic shock, so the heart, remember, cardiogenic shock occurs when the heart can't give the output that the body needs. And then congestive heart failure. While I might survive my heart attack, the long-term implication may be that I am now in congestive heart failure and faced with long-term consequences associated with not only my lifestyles that maybe led to the heart attack, but my, potentially I didn't seek treatment as soon as I could, kind of a whole bunch of things. Another thing that we can expect to see or potentially see in our patient Another reason why they're going to have chest pains or cardiac emergency is a dysrhythmia. So a patient who has a heart rhythm that is abnormal. It is not your normal, what we call normal sinus. It doesn't beat at the right rate or with the right lub-dub, and it causes serious issues in the body. What you see here are multiple different types of dysrhythmias. Basically, anything that's not what we call normal sinus is a dysrhythmia. It is a potential issue with our patient. Tachycardia is that patient who has a heart rate greater than 100 beats per minute. And it's a maintained or a sustained greater than. If you've just run a marathon, we would expect you to have a heart rate greater than 100 beats per minute. But as you rest and relax and recover, that heart rate should decrease. So if your patient's heart rate is not decreasing, that's tachycardia. Bradycardia is a patient who has a heart rate that is less than 60 beats per minute. This may be the result of medications, though. So again, you have to ask. And it's why it's important when you're talking about your sample to make sure they're not on any medications that might cause an abnormal heart rhythm or an abnormal heart rate. And these medications are life-saving, but they do cause some other complications for us. So, that's bradycardia. Ventricular tachycardia is when the ventricles are beating at greater than 150 to 200 beats per minute, kind of in that range. And as a result of that, over a prolonged period of time, we lose appropriate perfusion. And then you've got ventricular fibrillation. Fibrillation is kind of like a disorganized heart. And it means basically that you've got a patient whose ventricles are kind of quivering. So if you like Jell-O, and you've ever made Jell-O, homemade Jell-O, not store-bought, and you put it into the bowl, and then you shook the bowl and watched the Jell-O wiggle, that's probably the best imagery I can give you for ventricular fibrillation. And we will defibrillate. Those are the patients who the AED is going to help, hopefully. Why do we defibrillate? Why do we shock the heart? Well, we're looking to restore the cardiac rhythm. We're looking to get the heart rate to kind of do a hard reset, a reminder of, oh, that's not what I'm supposed to be doing. Let's fix it. And it can save lives. But we defibrillate, at not BLS providers, but ALS providers can defibrillate, patients who are conscious. And help to get the heart rate back into an organized rhythm again. We also will use, cardiac, CPR to support getting the heart rate back into a normal rhythm. And because if we don't have a defibrillator immediately available, remember, CPR is what we start first. And we have to recognize, though, that not all patients are going to survive, and not all patients are worth defibrillating. And I don't mean like they're bad people. I mean that they have a rhythm that defibrillation won't fix. And that rhythm is asystole. Asystole, or a patient who presents as asystolic, that's what you're used to seeing when someone dies in the movie. That's flatline. That's a patient who doesn't have any electrical activity in their heart. And we have to have electrical activity to get that restart. So when our patient presents with asystole, or they're flatlined, no amount of electricity is going to restart that heart. And nearly all of those patients end up dying. We've studied cardiogenic shock under our shock chapter. So we'll do just a quick review of this. Cardiogenic shock is caused often by a heart attack because cardiogenic shock occurs when the heart cannot provide the output that is necessary. It doesn't have the power to force that blood through the ventricles. And you need to recognize the shock caused by the cardiac event, so the acute myocardial infarction or the dysrhythmia, and treat it early so that it doesn't become a long-term problem. Congestive heart failure is also the potential cause for your patient's cardiac emergency. Congestive heart failure can occur multiple days after a heart attack has occurred because we've said the heart attack has the potential to weaken the heart muscle. A weakened heart muscle can't push the blood with the force that is necessary to get it through the body, and you end up with a backup of blood into the lungs. And the last thing you want is fluid in the lungs. So congestive heart failure, as we've talked about, presents with a fluid in the lungs. And you've got to be cautious with that because when you've got fluid in your lungs, you're not getting the oxygenation that is necessary to support life. You might have a patient who has a hypertensive emergency. So they end up with a systolic greater than 180 for a prolonged period of time. So as has been said, our systolic pressure is the pressure when the ventricle is under contraction. And so if our arteries are under a pressure of 180 millimeters of mercury every time the heart contracts, then there is the potential that those arteries will face damage. They won't be able to stay under the pressure. Some of the signs and symptoms associated with this, with hypertension, so hyper blood pressure, include sudden and severe headache, strong bounding pulse, and even a ringing in the ears. A lot of times patients will talk about being able to hear their heart in their ears. Some other common signs and symptoms. See, I believe I've already mentioned that at this point forward, just expect nausea and vomiting to be every potential patient. So nausea and vomiting, dizziness, warm skin. Patients who have chronic hypertension may have a nosebleed and sudden onset pulmonary edema. The nosebleed, the goal of the body is to get rid of some of the pressure. Well, the best way to do that is to empty the pipes. And so the only way the body can do that if there isn't already an opening is to use an opening. And so that's where you get the nosebleeds from. When we have chronic and severe hypertension that is left untreated, we have a patient with an increased risk of a stroke or an aneurysm. So if you think about those water balloons that you fill in the summer, and when you don't turn the water off, what happens to the balloon? The pressure in the balloon increases until it bursts. Well, that is what an aneurysm is. When the artery is under such pressure for so long, you actually have a risk of that bursting, the aneurysm occurring. So this seems like a good time to talk about the aortic aneurysm. So the aortic aneurysm occurs when the wall of the artery begins to weaken and bulge. And when that happens, that is a weakness in the artery. And that increases the risk that your patient will burst their artery. And, even if you don't know a lot about aneurysms, if I were to say your patient's going to burst their artery, I'm pretty certain you'd recognize that as a negative. And when you have multiple layers of the artery that are pulling apart, that's what we call a dissecting aneurysm. And we will talk about patients who have abdominal aneurysms, who will have we'll talk about aneurysms under stroke. The thing to remember is when you have a break in the wall of an artery and that then becomes an opening and there's leakage or it's a full burst, you've got a patient who is gonna die or gonna come close to dying if they don't end up in definitive care. This is kind of a comparison of your patient who is complaining of different things and how you will know whether it is an acute myocardial infarction or if it is a dissecting aneurysm. And the difference as you go through your OPQRST and the responses that you'll get. A dissecting aneurysm where you're getting multiple layers tearing away, takes some time. So you might actually have a little extra time, not to sit on scene, but to get them to care. It's not going to be a sudden death. You have a sudden aneurysm burst, and it's a large part of the body. It's the abdominal aneurysm, it's an aortic aneurysm. When you have the aorta opening up, obviously the survivability of that is fairly low if they weren't already in the hospital when it started. Signs and symptoms of the aortic aneurysm: sudden onset and sudden severe chest pain. Obviously, it's not going to get better with breaths. Different blood pressures, so their right arm, their left arm are showing different blood pressures. And it's full force. If it's happening 100%. Aortic aneurysms do not play. So when your patient is suffering from an aortic aneurysm, it's gonna happen, and it's gonna happen the way it wants to happen. These patients need to be transported quickly, but you do need to use caution. You don't want to create a rough environment for transport.